Thank you for joining my presentation on lung function assessment by impulse oscillometry in adults. My name is Terrence Shenfield, and I have been an education coordinator for the last 30 years at a major trauma center in Newark, New Jersey, and I also am the co-owner of A&T Respiratory Lectures. At the end of this presentation, you will know everything you need to know about this modality and how it's used to monitor patients' pulmonary function. Today's objectives are, first, I'm going to describe what is impulse oscillometry. Basically, it's a variant of forced oscillation technique first described by Du Bois over 30 years ago. Secondly, I will be describing the advantages over spirometry. There are certain advantages over spirometry, and one of the major advantages is that it doesn't really take a lot of patient effort to get good values. So in other words, with spirometry, sometimes you have to coach the patient and you have to do various, times to make sure they're doing it right. But with this test, it's really kind of simple to do, and it doesn't really take much patient effort. Thirdly, I'll be describing the structure of the impulse oscillometry system. Basically, I have a short little video that shows you exactly what it looks like. I'm going to show you the different parts, so this way you have an idea what it is. And then finally, I'm going to describe different types of pulmonary disorders that may benefit from this type of test. So by the end of this presentation, you're going to have a good handle on this process. As you can see by the picture, this is the typical settings for doing the test. And basically, you have the patient put their mouth on a mouthpiece, you have nasal clips on the nose, and you notice that they got their hands on the cheek, because what they do is they want to minimize the movement of the cheek and the muscles there, because it could impact the values of the test. Now, I can explain exactly what it is, but I have a very short video on the next slide that describes how it works, and they actually do it on a pediatric patient. So stay tuned. You'll know a lot more by the next slide, and then I'll continue talking more about the value of this test.
Tell me about the impulse oscillometry system.
IOS is a test that's used to detect lung disease. It's a much more sensitive test than spirometry. Spirometry is used as a pulmonary function test and is also a breathing test. It is used to detect lung disease, but the IOS is a much more sensitive test, and it's offered here at the St. Tammany Parish Hospital Outpatient Pavilion. The test takes about 20 to 30 seconds. And you'll do a minimum of at least 3 trials. So I'd like to show you here with our young patient how easy this test is. Can you come stand over here? Now I want you to place your hands on your cheeks and just breathe in and out, nice and easy, just very gentle. Go ahead and get your mouth on the mouthpiece. Put your hands up on your cheeks and just relax. Just breathe in and out. Doing a good job. Just relax. You're almost finished. You're going to feel a little bit of that air going in and out through your lungs there. Very, very good. Okay, you can come off. We'll do about 2 more of those and then you'll be finished.
Okay, thank you.
Impulse oscillometry, commonly known as IOS, is a variant form of forced oscillation technique, commonly known as FOT, and it was first described over 50 years ago by Du Bois. The benefit of this test, it allows to do measurement of resistance and compliance measures with passive breathing. So what that means is the patient breathes a normal tidal volume in and out, in and out, in and out, and then what they do is they superimpose some sound waves on top of that. And sound waves are energy waves, and what they can tell by the disturbances in flow and pressure caused by these waves. And then they have some special calculations where they could describe different resistance of airflow. They could also talk about reactive parameters in the airway. And the beauty of this test is it requires minimal patient cooperation, and it can be easily done versus spirometry. So spirometry is a great test, but it takes patient effort, where this test really takes minimal patient effort and you get just great results. One of the real benefits of this system is it can differentiate between small airway obstruction and large airway obstruction. So it's actually more sensitive than spirometry in this category. It's a great way of measuring asthma. It's a great way of measuring bronchodilatory response. So this is a great tool for patients with obstructive pulmonary disease, and because it really takes minimal cooperation from the patient, so you could use especially children. They've done some studies where children could use this process because it really doesn't take much effort for them to do it. And it actually could identify small airway disease better than spirometry. So that's a little bit about it. We're going to get a lot more into it as we go along. I thought I'd offer you a graphical display of what the test looks like. Basically, you could see the oscillating waves superimposed on the graphics that normally come from spirometry. And these tell a lot more information than normal spirometry. So you could see the superimposed waves on top of it, and they do some calculations on this where they can make interpretations of small versus large airways, and it's a really good test. We'll get more into this a little bit later. Let me tell you some of the major advantages of impulse oscillometry over spirometry. One of the first things, and very importantly, it's a really easy test to do. It really doesn't have much effort from the patient. All the patient has to do is put a nose clip on, hold their cheeks, and breathe normally at normal tidal volumes. You're not like no deep breath, hold it, no blowing out, no blow, 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 none of that. It just breathe in and out, tidal volume breaths. And then what they do is they superimpose those radio frequencies on top of that. Also, what it does, it measures resistance of the airway and reactants at different frequencies, offering very important information on how the lung is doing. The word resistance, I'm sure you know, think about asthma, think about secretions, but reactants might be a word that you're not familiar with, which I'm going to get a little bit more into details a little bit later. Think of reactants as compliance of the lung, the elasticity of the lung. The only requirement for the patient to do is to be relaxed, breathe normal, and while these sound waves are superimposed on breathing. The beauty of this test, it can detect subtle changes in small airway function that is not normally found in spirometry. So it could really determine whether you have peripheral air disease much more efficiently than spirometry testing. So these are some of the major advantages of the system, and we're going to get a little bit more into definitions as we go along. So how does this system work? Basically, a patient comes into the pulmonary function lab. They sit down. They put their mouth over a mouthpiece. They have a nose clip. They also hold their cheeks from moving. They keep their cheeks stationary by putting their hands on their cheeks. At this point, they breathe tidal breath. So they're breathing in, breathing out, breathing in, breathing out. While this is happening, a loudspeaker actually transmits sound waves into the lung. These sound waves are set off at different frequencies. They go typically from 5 hertz to 30 hertz. Lower hertz actually go deeper into the lung, where higher hertz actually stay up in the upper airway. So these sound waves, which are essentially pressure waves, cause changes in pressure and also have changes in airflow. So pressure impacts airflow. By measuring the magnitude of change in pressure and flow, you could really determine the mechanical properties of the lung. Obviously, there's some kind of computer algorithms that are actually converting this, But the beauty of this is that the patient is just breathing tidal breaths with this, no deep breath, no blow, 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 and they're getting all these accurate measurements. Actually, some of the measurements are more accurate than spirometry. Waves of a lower frequency travel deep in the lungs to the alveolar area and then are reflected back, and higher frequencies are reflected in the larger airways. So that's the basics of how this test works, and I got more to show you. So let's talk a little bit more about the technique. As you know, when you send in these sound waves over tidal breaths, they actually create different frequencies going into the tidal breath. So they start anywhere from a frequency of 5 and they work their way all the way up to a 30. They're measured in hertz. Lower frequencies go deeper into the lung, which can determine small airway disease. Higher frequencies can actually impact larger portions of the airway, you know, the bronchi and the whole bit like that. Frequencies above 30 can cause discomfort to the patient. So that's why they always do the range of 5 to 30. So as you're breathing in and out, in and out, in and out, they put different types of frequencies with the sound waves from the speaker, and then they measure pressure and flow at the airway. They measure pressure and flow with a pressure transducer and a pneumochromatograph, and they are present at the mouthpiece. So this is where they get a graphical display of pressure and flow, and this is all superimposed with the sound waves that come along with it. From this, you could do great interpretation of exactly what kind of problems you have with your lungs. This is a simplistic representation of the process. As you can see, we have a couple of different parts. For example, this part right here, A, that is the loudspeaker. And B is the bias flow, because you always introduce some bias flow into the system. C is a pneumotac, so this is your pneumotac right up here. D is your airflow, so that's how you do that. Then E is your opening pressure, airway opening pressure, and then finally F is the mouthpiece with the bacterial filter. But as you can see from the display, the lower the hertz, the deeper it goes into the lung fields. So when you're talking about peripheral small airway disease, think about it starting with lower hertz. Higher hertz actually work with larger airways, so they could tell any kind of obstructive pattern in the larger airways, where the lower hertz will tell peripheral lung disease, which is really important with asthma and many other conditions. So there's a lot of different terminology that I have to cover for you to understand impulse oscillometry. And before we get into different types of respiratory conditions and what the values mean, we really need to understand some of these languages. So some of the topics we'll be talking about is impedance, resistance, reactance, resonant frequency, area resistance, coherence, and reference values. We're going to go into each one of these in detail so that when we apply conditions of the lung, you'll understand what we're talking about. With impulse oscillometry, there are different terms that are used. Each of these terms are quite complex, but I'm going to try to keep it as simple as I can. For example, one of the terms is impedance. When you think about impedance, respiratory impedance is the sum of all forces which oppose the generated impulse. So what is a generated impulse? As you put sound on tidal breathing and that you do it at different frequencies, the lungs' ability to reject or push back against those forces is called impedance. Impedance is measured at any frequency and is the ratio of the difference in pressure and changes in flow at that frequency. As you do different frequencies, you will see different levels of impedance. Depending on the region where the pressure is measured, impedance varies. So impedance varies based on impulse and based upon what lung regions you're going to, it goes to. Another common term that I'm sure you heard about is resistance. When we think about resistance in this category, think about that it's derived from the impedance value, and that each part of the airway, the central airways, the peripheral airways, the lung tissue, the chest wall, all have different forms of resistance. And you could say globally that over 80% of the resistance is contributed to the central airways, where the small airways only about 20%. So this is another term you want to know besides impedance, it's the resistance. Another common term used is called reactants. When you think about reactants, think about two different components. One is inertia and the other one is capacitance. So inertia means that the airway really doesn't want to move. It doesn't want to expand. It just wants to stay in its steady state. So that is called inertia. And capacitance is, think about compliance. You know how the compliance of the lung, how stiff it is? So capacitance is like compliance, and inertia is how a matter, or say the air column, doesn't want to expand, doesn't want to move, it just wants to stay in a fixed position. These two terms make up what is known as reactants, and this is another term we use with this test. Resonant frequency is described as the frequency in which the inertial properties of the airway and the capacitance of the lung are equal. A normal value for resonant frequency is 7 to 12 hertz. This means is when the inertial properties of the airway, where the airway doesn't change in size and the compliance of the lung doesn't change, it's all equal. And typically this is done at the range of anywhere from 7 to 12 hertz. When you think of the word coherence, think about this as a way of determining the validity and quality of test results. Normally, you want a value between 0 and 1, and ideally, it should be greater than 0.8 at 5 hertz and 0.9 at 20 hertz. So this is a way of doing quality control testing on your patients. So it's called coherence. So why do we want to offer this test over spirometry? And we might want to do this with conjunction with spirometry, but this test has a lot of advantages. Some of the advantages is it's a very portable device. Actually, it can be brought to the bedside. It's easily maintained. It's also very easy to calibrate. Basically, all you need to do, you don't need a 3-liter syringe to calibrate this type of device. All you need to do is, like, they have a special platform where they let you calibrate it rather easily. Also, it's very user-friendly for both the patient and the clinician. What that means is the patient, it doesn't take much effort from the patient to get a valid test. Versus spirometry, where you have to coach the patient and make sure the patient does everything correctly. And if you get a patient who is young, or if you get a patient who's really old, sometimes spirometry can be quite difficult with that population. But with this device, it's really rather easy, and the whole test takes less than a minute. So the patient could do this whole process in less than a minute. Another great feature of this particular device, it's easy to export data. You know, most systems have export feature where you could see the results of the test, but very easy to export. So these are some of the key advantages of this device over spirometry, or you could do it within conjunction of spirometry. So just keep that in mind. So I wanted to go over some terms with you and sort of simplify them because, you know, they used a whole new set of terms when doing this type of test, and they have new symbols, and I just wanted you to get a clearer understanding of that. For example, when they talk about impedance, which is typically ZRS, impedance is nothing else but flow and pressure. You know how flow and pressure is graphically displayed. So think about, when you think about the word impedance, think about flow pressure waveforms. That's what I want you to think about. When you think about resistance, which is RRS, resistance is commonly found in obstructive disorders. Think about narrowing of the airway, think about secretions in the airway, think about someone who has asthma or COPD. That is resistance. So resistance is a key point. Another fancy word is called reactants. Reactants, ZRS, is nothing more than compliance of the lung. It's how the lungs recoil after being stretched. Some patients who have poor compliance are ARDS patients, patients with fibrosis have very non-compliant lungs. Someone with scoliosis or kyphoscoliosis has very poor compliance. So think of the word reactants as compliance. When you think of the area of reactants, when they say area reactants, they commonly call that AX or XA, but most likely they're going to call it AX, area or reactants. And when you think about area reactants, this is area under the curve that is more compliance related. So when you think about the area reactants, and it's commonly known as AX, think about area of the curve that's involved with compliance. In regard to resonance, that's the frequency in which lung tissue moves. When you think about frequency, commonly known as FRES, that's a response to force of pressure with wave signal. And if you think about coefficient availability, CV, that's a statistical determinant to determine whether a trial can be reproducible. The rest of the terms are not really that relative, but I just wanted the key big ones: impedance, which is flow pressure, resistance, which you know, and reactants, think of compliance. Now with that information, we're going to go a little further. So I wanted to give you a good idea of when you interpret these values, when they say R5, R20, FRS, AX, X5, frequency, R over X. You know, it's like sort of kind of crazy when you think about all this, but this is how you can interpret the test. So let me just show you this. This vertical graph right here on the left, right? This one right here. Think about that as being flow and pressure. So when you think about this graph on the vertical axis, it's flow and pressure. When you look at this graph on the horizontal axis right here, that's frequency. And so the frequency they use is hertz. So, you know, sound waves can be different levels of hertz. They could be 5, they could be 10, they could be 15, they could be 20, all the way up to 35. Most tests are done between 5 hertz, which is right here, and 20 hertz, which is right here. So remember this too. The lower the hertz, the deeper it goes in the airway. It goes all the way down to the alveolar. So lower hertz goes down to deeper parts of the airway, where higher hertz is more in the central part of the airway. So, you know, the main bronchi. So when you think about it, the true value of this particular type of test is at lower hertz, because most diseases take place at the lower peripheral airway, way down close to the alveolar. Asthma, COPD, you know, cystic fibrosis, the whole list goes on, emphysema, everything goes. So most of these problems are small airway disease. So now we're going to go to the second part. Up on top, you see the solid line right here, right? That solid line, that is resistance. And we explain what resistance is. I mean, you know what resistance is. When you think about resistance, so think about it. You notice how R5, that means at a frequency of 5 hertz, the resistance that is found is right here, right? R5. and you notice that the resistance is higher in the small airway. It makes sense. You know, the airways get narrower, and that's where the disease process comes. And then as you get deeper, when you start using higher hertz, and using 20 hertz, which goes down to the main airways, the big airways, you get this, you get less resistance. The bigger the airway, the less resistance. So you could see the curve from R5 to R20, and this is a calculation they use. The difference between R5 value and the R20 value gives the calculation for central airway disease. When you think about R5, think about asthma, think about COPD. When you think about R20, think about main type of disease process that impact the bigger airways. So we understand what R means. So R is resistance, 5 is 5 hertz, R20 is 20 hertz, and we're going to get more into this. Now let's look underneath the bottom of the graph. Remember I was telling you the bottom part, which is commonly known as reactants right here. See the X right there, reactants? Reactants, another word for reactants is compliance of the lung. So again, we were talking about patients who have stiff lungs like ARDS or fibrosis. These patients have very stiff lungs. So when you look at this, again, instead of calling it R5 and R20, they call it X5, which is a measurement of reactance or compliance of the lung. And then instead of it breaking down to the R20, they look at this value right here, which is FREC, which I don't want you to pay too much attention because it's not that clinically useful. What's really important is your values of X5, which is dealing with reactance or compliance. And another very important factor is this graph on here. You see this area right here underneath? That curve is called AX. That's a very, very important graph too. The smaller the AX, the more compliant the lung is, which is a good thing. You know, you don't want lungs. So any kind of therapy that could change the X5 and the R5 and the R20 and the AX that you could visually see is a good thing. So remember, in summary, the lower the hertz, like 5, go down to the small airways, and the higher the hertz are a measurement of the upper airway. The difference between the R5 and the R20 is central airway. So if you're going to give a bronchodilator to a person, you're going to see the most significant changes in R5 initially, but you might also want to look for other changes. And if you have a problem with compliance issues, you really want to look at your X5, and you want to look at the area under the curve, which is commonly called AX. So that's a brief, counted down and dirty type of thing to do. And remember, the vertical graph here, right here, all it is basically flow and pressure. So, and that is called impedance. Okay? All right, guys, we'll move on. I wanted to show you this. These are a listing of reference values for healthy adults. They found that the reference values for children vary so much because a big common denominator to determining reference values and IOS values is height. So children grow. So as children grow, so does their reference value changes very much. So it's kind of difficult to predict reference values for children. But with adults, they did some studies here, and they looked at some studies from Australia, they looked at Europe, they looked at North America, they looked at Asia. And the truth is, they're pretty stationary. In other words, they don't change much with that. So really don't pay too much attention to reference values. What you really got to do is interpret the test results and to see if you could see any kind of changes. You know, reference values are hard to nail down. In adults, they're pretty well homogeneous. With children, they're not, because like I mentioned before, children grow and get taller, and height is a very important variable in regard to this test. As I was mentioning on the previous slide, some takeaway points you should understand is, for adults, both the R5, which is resistance, X5, which is reactance or compliance, they're kind of similar. And the difference is with R5s and X5 values in children show a lot of variability due to height and age. So it's very hard to come up with reference values for children, but the reference values are pretty consistent with adults. They're not that much different. And I just wanted you to know that. At this point, I want to go over some clinical applications of the iOS test. And obviously response to bronchodilators. If someone's an asthmatic, you could sort of differentiate between a COPD or an asthmatic. You can see who responds, who doesn't. You could also see if an asthmatic has airway remodeling. We could also do broncho provocation testing. We did a lot of tests with asthma and COPD patient, interstitial lung disease, ILD. They also did significant number of studies with exposure to occupational hazards and smoking. And one of the telltale signs, which I'm going to tell you a little bit later, remember the World Trade Center and all the firefighters and the police and the emergency support teams that went up to the World Trade Center? They all ended up getting some kind of, not all of them, but a significant part of them ended up getting some kind of lung disease. And, I'm going to go a little bit more into that. I'm going to talk about central airway obstruction, talk about cystic fibrosis, and then I'm going to talk about some other diseases such as graft function, lung transplant, sickle cell disease. So this test can be used on a host of different types of modalities and different conditions of the lung. Our first case is a response to bronchodilators. How do we measure a response to bronchodilators? And typically, if you do spirometry, if you have a response on your FEV1, that is a positive response on normal spirometry test. But in regard to the iOS, some of the key things you need to know is, remember, if you see a significant response in the R5 value, so for example, on pre-bronchodilator, before they take a bronchodilator, you look at their R5 value, right, and you determine what it is. You also look at your R20 value, you determine what it is, and then you find the difference between R5 and R20, which is central airway disease. Now, so what they have found, that with someone who is given a bronchodilator, their R5 value, instead of being up here, will go down a little bit like it's right about here. And then the R20 value will go down a little bit too. And also you might see some improvements in compliance where the X5, which was originally down here, might go up a little bit up here. And also what you see is a decrease in the AX, which I was mentioning to you, which is a compliance factor. So that is the response for the bronchodilator. And I just wanted to show you some of the studies that support this. They have shown that iOS is much more sensitive than spirometry in the case of children as a predictor of asthma and, most importantly, a response to treatment. It's very good to use with spirometry, but it's sometimes, you think about it, sometimes children under 6 years of age don't really do good spirometry, yet with this test, you get some really good results. iOS parameters are also highly sensitive to bronchodilation, so if you have a positive response, you're going to see significant changes of R5, R20, and you're going to see significant changes of the difference between both, and also you'll see significant differences with X5 and AX. A bronchodilator response assessed by IS is also demonstrated to be frequency dependent between R5 and R20. Also, they say that a bronchodilator response greater than 40% decrease in R5. So basically, if your R5 goes down by 40%, that's equaling significant airway reversibility. So in other words, if your R5 value goes down by 40% or greater, you really had a profound effect by the bronchodilator. And I'm going to get a little bit more into that a little bit later. But that's how you do it. So you do a pre and post bronchodilator study. but instead of looking at FEV1s, you're going to be looking at R5s and R20s and X5s and AXs. And the sensitivity of this test is much better. Also, the fact that patients can be more compliant about doing it with the elderly population as well as the children. So this is a great test. Another group of patients who benefit is patients who get a broncho provocation testing. And the reason for this test, we wanted to determine how the airway responds to any kind of allergen such as histamine or methacholine. And this test can be very helpful in certain populations. Typically, if you're doing spirometry testing and you use some of these agents like histamine, you're looking for a 20% fall in FEV1. That's with normal spirometry. But they found by using the iOS test that you could get similar, if not better results with patients doing this. And the best part of this, there's certain patients, like I mentioned before, like children under the age of 6, also adults who are, older and elderly, and also people who are cognitively impaired, that they don't follow good directions with normal spirometry, can benefit from this test. So again, what you'll be looking for, which is close to this 20% FEV1, would be a drop in the R5 value. And that's how you could determine how effective the test is. So I have some really interesting slides. The next 3 or 4 slides are going to be really interesting because the most common modality to use iOS is for patients with asthma and COPD. This gets the lion's share of this test being used on most patients. And probably most patients with spirometry testing either have asthma or COPD. So this is the big dog on the block, as they say. So of all the uses of iOS, asthma is the really one you really want to test with. And one of the key points of asthma is airway resistance. And in this particular test, airway resistance is measured by R5 values, right? So R5 values, R20 values, right? And we know what R5 is. R5 is 5 hertz. R20 is 20 hertz. And they have a calculation where they do the difference between R5 and R20, and that's like peripheral lung capacity. Now, another very important tool they use for asthma and COPD is looking at AX. And remember what AX is? X is reactants. Another word for reactants is compliance. So they look at the area under the curve. They look at this area right here, and they look to see if there's any kind of positive response as a result of that. So one of the hallmark signs of asthma and COPD, especially with the iOS test, is to look for changes in R5, changes in R20, and changes in the R5 to R20 ratio, and also to look at under the curve at compliance changes, which is measured by AX. So keep that in mind because our next few slides are going to go a little bit more detail about this. Okay, so this is a great slide because this is going to be a slide that you get as a result of an iOS test. And in this particular case, they were looking at a patient who came in with severe asthma, and they wanted to know, did they respond to a bronchodilator, salbutamol? And what they did, kind of importantly, they did both spirometry on this test, where they looked at the FEV1, FEF 2575, and they also did the iOS test. So let me show you. The results of the spirometry test were right here. So pre and post bronchodilator, right here. So that patient had a response on the FEV1 from the bronchodilator of 16%. They also had a response on the FEF 2575, which is one of the only valid tests we have for small airways, of 15%. But what the real beauty was, there was a much more profound response with the iOS test. For example, this area up here, this graph right on the top, right there, is pre-bronchodilator test, right? So you can see the dark blue line is a pre-bronchodilator. So when you think of this value right here, what is that? 5 hertz, 10 hertz, 15 hertz, 20 hertz, and so on, all the way up to, to 40 hertz. What they noticed that the R5, right, the R5 right here, this was pre-bronchodilator. The patient had severe bronchospasm. And also, their compliance here with their X5 was up here. So, no, I meant down here. I apologize, down here. So what happens was they gave him the bronchodilator, and look at the significant response. Look at the difference between X5 up here, pre-bronchodilator versus post. Really significant change. This whole area over here, the distance between this and this was a change. Really significant. And then remarkably, we see an improvement in compliance of the patient by this. This is right here. This is the pre-bronchodilator right there. And after the post-bronchodilator, look at the change. So you look at the distance between here. And, you look at the 5-second rule, the 10-second, 15-second, 20-second. But the results from this test, this is a standardized test. These are the kind of results you get. The R5 showed a 48% reversibility. The distance between the R20 showed a 23% reversibility. The distance between the R5 and the R20 showed a 75% change. The AX, remember I was telling you about the AX, showed a 79% improvement in compliance, and the X5 showed a 58% improvement. So this test, in regard to reversal of bronchospasm by using a beta agonist, was phenomenally well. So I wanted to show you this slide right here. And the reason I'm showing you this slide is because it shows when you actually do a spirometry test with asthma patients and you do an iOS patients, there's a difference between the results of a spirometry versus iOS, which in a way, I feel the iOS is much better. Another word for iOS is AO, which is, airway instead of iOS, same thing. So let me show you this. So when you do an iOS test or you do spirometry, typically the R5 value, right, or the FEV1 value is significantly changed. So you could see how they did patients who were healthy volunteers, ones who had mild to moderate asthma, those who had severe asthma. You could see some pronounced changes. But the very important part of what's saying here, if you notice, look at the central airway resistance, which is the R20. So the difference with central, so basically, when you do iOS, you don't see any significant change at all. It's exactly the same no matter what kind of patient you have. So what does that mean? What does it mean that the R20 value, which is a value for central airway, that you don't see any change between a healthy volunteer, a mild to moderate asthma, or severe asthma? What does that mean? And typically, the FEV1s are indicative in this group. So the difference between a spirometry offering the FEV1 and the iOS, FEV1s will show a change where the iOS shows no change. So I'm saying to you that asthma is a real product of small airway disease. So really, the most sensitive test is the R5. And when you get into the R20, which is typically measured by spirometry, it's invalid. It's not a valid test. So in regard to sensitivity of a test in regard to asthma, my thoughts are that the iOS is a much safer test right there, and it gets the gold star. we're looking at the R20, which is the same thing as looking at spirometry values, is not changing because it's exactly the same in all populations. Another key benefit of working with the iOS, especially when we're talking about asthma and COPD patients, because they looked at reversibility, like how do you determine if a patient has asthma or if they have COPD? So if you are doing an FEV1 on it, they did a test here where they gave a bronchodilator for both an asthmatic patient and a COPD patient. And then they did FEV1s. What you showed was the asthma patient had improvement by 8%, and the COPD patients had an average improvement of 8%. You cannot differentiate between them. But when you did the iOS test, you could clearly see the percentage changes with asthma versus COPD, 24% versus 40%. What does that mean? That means you could sort of diagnose someone more effectively as having asthma rather than COPD based upon using iOS rather than using FEV1 as a gold standard. So it shows you the sensitivity of this test in differentiating between an asthmatic patient and a COPD patient, but when you look at the spirometry test with the FEV1, you really can't tell a difference with it. So another group of patients who benefit from iOS testing is patients who have interstitial lung disease. Interstitial lung disease manifests itself by having a restrictive pattern, and also the elastic recoil of the lung, or the compliance of the lung, is really poor. So what they do, if you were doing an iOS test on these patients, what you would typically see, because it's a restrictive pattern, you would see a decrease in X5, and also you would see a decrease in R5 in these particular patients. They also have done a recent study by Reham. They looked at the correlations between oscillometry and spirometry in these patients, and they found that iOS was used as a better predictor of ILD rather than spirometry testing. And what they found also, another study by Mori and company, they found that these kind of patients typically had a decreased X5 and a decreased R5. But the real value of this test is the fact that it's used in early diagnosis of ILD, and it shows changes in these values prior to you see changes in spirometry. So it's a little bit more sensitive. Another group of patients who benefit from iOS are patients who have impaired lung function due to exposure to occupational hazards or smoking. So what they found was, especially when we talk about patients who were in the World Trade Center when it came down, and all the dust and toxins that came out of that building, a lot of firefighters, police department, emergency support people, and even people who worked in Wall Street and lived in Wall Street at the time have some kind of lung problems up to this date. And they found that the group who received spirometry showed not much changes in airway, but the people who did the oscillometry showed much more difficult changes that were picked up sooner. So the key point here is, again, iOS shows greater sensitivity to changes in airway than spirometry does, and they proved this with the group that were from the World Trade Center who went down, who were exposed to all those toxins and everything that came down with it. So typically in this group, you will see an impact on your R5, and you'll see an impact on your X5, and of course, any impact on X5 will actually have an impact on AX, which is a great indicator. Remember, R5, resistance, AX, X5 is compliance. So more sensitive test. Great news. Another real benefit of iOS is central airway obstruction. And central airway obstruction can be defined as any kind of damage or changes to the central airways, such as the trachea or the main stem bronchi. And the most clinical conditions that can occur at this are either malignant or benign diseases, such as those with cancer. So they have found that this particular test, the iOS, is very sensitive to determine central airway obstruction as measured between the difference between the R5 and the R20. But the real beauty of this particular test, remember, R5 is small airway, where the R20 is central airway. So if you start seeing marked drops and marked changes in the R20 value, which comes in around 20 hertz, because remember, the higher the hertz, the more it impacts the larger airways, and central airways are large airways. So this test can be really relative for those patients who suffer from this, because you can get a full diagnosis of what's going on with them. Also, what you're going to be looking for is changes in the under the AX. This is a very important factor with central airway obstruction. So, numerous studies have shown that this to be quite beneficial in these particular cases, and it can be very sensitive. Like, we have more sensitivity to changes with asthmatics and COPDs, and I'm sure we can do the same application to those with central airway obstruction that may not be picked up with normal spirometry. There have been a few studies done with patients with cystic fibrosis, mostly in children. And some of the common findings we're finding with patients who've done iOS testing with cystic fibrosis is that you will have an increase in your R5 values with this group. You will also see a decrease of your X5 values. So what does that mean? That means if you have an increase in R5, that means you have more resistance to the airway. And also if you have a decrease in X5, you will actually have more stiff lungs. So these are some common findings that you find with this, and they also have done some studies with this group where they looked at the use of CAT scans, DLCOs, and iOS patients, and they actually was able to reveal hypoventilated regions of the lung, which show the restrictive parameter with it. So there's some benefits to this particular test with this particular group. Implementing iOS in patients with geriatrics and pediatric clinics can be very important in this group. For example, a lot of geriatric patients cannot follow good orders to do spirometry testing, and the same thing goes with pediatrics. Currently, anyone from 6 years and younger can maybe have a difficult time with spirometry testing, but iOS seems to be a very good solution to this. Also, studies with interstitial lung disease, they need more research, but they find that these testing are being very beneficial to the diagnosis and treatment of these disorders. And also, very important about iOS is it seems to be a little bit more sensitive to diagnosing early stages of diseases of fibrosis before sporadic changes. Before you see any kind of spirometry changes in the lung, you will see changes with this test. So I believe the test should be utilized a little bit more. I know they're doing extensively in Europe, and I think it's a great test for us to have here at the bedside and also in the laboratory, and could benefit patients with their diagnosis. So in summary, this is a great tool to use in younger populations and older populations, as I mentioned earlier. Another thing, it has greater sensitivity with asthmatic patients and COPD patients, and can really be more sensitive about differentiating between the two. Patients with impaired cognitive ability or impaired neurological diseases who can't follow commands can benefit from this test because it's much more simpler to do than spirometry. And new research is coming on with patients with ILL ILD and cystic fibrosis. So, it's going to be beneficial for this population, and we're going to see more research coming out as we move ahead. Here's a great list of references for you, and more importantly, if you look at the bottom, I have a YouTube reference. This is where a doctor from Glasgow, Scotland, actually does some testing, and it's on YouTube, and you can really learn a lot from that. And I want to thank you for joining my presentation, and I hope you learned a lot today.